Morning, everyone. We're just going to wait another 1 or 2 minutes and have people join in. My panelists are joining as we speak. We've got a couple more panelists joining. There's Brock. We got one more joining. All right. Good morning from Portland, Maine. I want to thank everyone for joining. Um, Let me just give you a little bit of background of this presentation. So back on June 4th, as part of the Stroudwater virtual conference, we had these panelists join for a discussion around abundance-based leadership applied to kind of uncertain times. And we had a number of people reach out and really enjoyed the presentation to the extent where people were saying, "Hey, could you maybe a podcast series on this? Maybe some type of a series where these topics keep coming up," because many thought that it was very impactful to their organizations. Well, with the passage of the Budget Reconciliation Act, there is a time now where there's a lot more uncertainty going forward. And with that uncertainty, it was the perfect opportunity to bring back these rural healthcare leaders to discuss not only the Budget Reconciliation Act, but how they're thinking about applying it to their operations. Again, this uncertainty. So my name's Eric Schell, and I'm the chairman at Stroudwater Associates. For the past 28 years, I've been traveling around rural America, helping rural hospitals. And in my travels, I occasionally come across what I consider very abundance-minded leaders. And the three panelists that I have, Mary Ellen, Kevin, and Benjamin, are all probably in the top 10 of abundance leaders that I've met in those travels. So I'm just really excited that they're joining us again here for this presentation and sharing kind of their thoughts. So with that as introduction, I want to jump in and see if we can get us going here. I want to do a quick introduction. I just talked a little bit about myself. In addition to the three hospital panelists, we have Brock Slabach, and it's, as you know, Brock doesn't even need to be introduced, but I'll just say a few words. I met Brock back in 2002. He was the administrator of a critical access hospital in Southwest Mississippi, a young superstar at the time. And then shortly after, in 2008, he joined the National Rural Health Association and is now the Chief Operating Officer. I consider Brock the heart and soul of the National Rural Health Association. And as many of us have seen him speak in the past, we enjoy hearing what he has to say and his perspectives. So that's Brock. In addition to Brock, we have Mary Ellen Pratt. Mary Ellen is CEO of St. James Parish Hospital, a critical access hospital in Lutcher, Louisiana. She's dedicated her career to rural healthcare. I met Mary Ellen back probably shortly after I met Brock in the early 2000s. She was the CEO of a critical access hospital in Mississippi. And she's been involved in pretty much every rural organization you could be involved in over the last 20 years. We got Benjamin Anderson. I met Benjamin back in 2017, 18. And at a presentation at the National Rural Health Association's Critical Access Hospital Conference. He is now the Chief Executive Officer of Hutchinson Regional Healthcare System in South Central Kansas, and a true force in rural healthcare. In addition to Benjamin, we have Kevin DeRonde, CEO of Mahaska Health. He's located in Mahaska Health is located in Oskaloosa, Iowa, southeast Iowa. I met Kevin back in 2018 when he had just joined Mahaska Health. The hospital was struggling, and through some of his leadership, and he'll share some of that with you, the organization is now absolutely doing things that I haven't seen in rural hospitals before. So, a couple of interesting things. Kevin did attend Iowa State. He'll be playing football on Saturday against Kansas State. So from Dublin. So pay attention to that. And um, anyway, yeah. So that's the introduction. If you want more information on them, the presentation from June 4th, it's available on our website. There's more details about them. So with that, what I wanted to do is start this conversation with a better, to kind of introduce the concept of abundance thinking and infinite game mindset as each of these participants and even Brock as well clearly fit this abundance infinite game mindset. And so I came across this abundance mindset. It was a Stephen Covey concept from his seven habits of highly effective people from from 35 years ago. And just in short, he differentiates or the abundance concept, the scarcity concept, where essentially scarcity-based people they believe that there's a pie out in this world, and if someone were to get that pie or a piece of that pie, it would come out of me. And so this scarcity mindset is destructive and it creates unnecessary competition. And unfortunately, it often rises to the top within our organizations, in our healthcare organizations, versus an abundance mentality that says if there's a pie of success in the world and Kevin, you're successful, the pie grew for everybody. Completely 180-degree perspective. And essentially this scarcity mentality is a zero-sum paradigm of life, where the abundance mentality, flows out of this deep inner sense of personal worth and security. It's a paradigm. There's plenty out there and enough to spare for everybody. It results in sharing of prestige, of recognition, of prowess decision making. It opens possibilities, options, alternatives, and creativity. I'm reading from the 7 Habits of Highly Effective People there, but to really introduce it. And what you're going to hear through these 3 and 4 leaders is how they apply this thinking to their organizations. The infinite game mindset. This was the concept that Simon Sinek developed in his book from, gosh, I think it's about 5 years ago. It was right before the pandemic, where the infinite game, he differentiates the infinite from a finite game. Most people play a finite game in which there's known rules. Let's think of a football game. Known rules, known players. There's an end. We know exactly it's finite. There's an end. And in that, there's a kind of there's rules to be played, and we have to follow through. And what he says is in the world of business, we in business deal in an infinite game where there's no known players. The rules are out, are there or not there. And what Simon really talked about was your goal in this type of organization is to perpetuate your existence to promote your cause. And when we apply that type of mindset to leadership, I just want to read a short paragraph on that. Um, Adopting an infinite mindset in a world consumed by the finite can absolutely cost a leader their job. The pressure we all face today to maintain a finite mindset is overwhelming. For most of us, almost any kind of career opportunities we have are all tied to how well we perform in the finite game. What profit did we make in this quarter? What was our census this month? All of that is finite thinking. We falsely tie our own value or self-worth to how we perform in the finite game, and any hopes that we may do anything other than play with a finite mindset seem completely dashed. Bowing to the pressure of the finite players around us is the easy and expedient choice. This is why it takes courage to adopt an infinite mindset. The four people that are on the call, the three panelists and Brock, I consider at the high end of the infinite game mindset, applying these abundance characteristics. And I think as you listen to their story about their hospitals, we've given them each of them about 5 minutes to talk about their hospitals before we can get into the panelist discussion. And then at the end, open about 15 minutes for questions. So with that, with those concepts introduced, I'd like to turn it over to Kevin DeRonde from Oskaloosa to talk a little about his hospital. And as he talks, think about this abundance infinite game mindset through the words that he's saying and how he applies this to his hospital. So Kevin, would you take 5 minutes and kind of touch on your health system?
You, Eric. No, we're a 25-bed critical access hospital, and we just want to start off. We've got such an amazing, humble team of people that just want to love on patients. And we have 17 physician medical directors. We have no business having that many medical directors, but when you get 25, 30 professionals in a room once a month for 3 hours to talk about how to advance care, it's really humbling. So we pride ourselves on being physician and nurse led. As the administrator, my role is to care for the caregiver, which I stole from Ben, and it's so true. We're here to foster an environment where medical staff can really focus on the patient, and so now having OB/GYN services, full-time cardiologist, ENT, surgical oncology for a 25-bed hospital is really humbling. Financial wise, gosh, back in 2017, we got down to 7 days of cash on hand. And so that was a bit of a wake up call for our facility. And so thankfully, we were able to perform a strategic financial operational assessment. From that, those findings really was a catalyst for our strategic plan. And then we also implemented a 10-year recruitment plan. So we hosted over 200 students the last couple of years, which is a lot of fun. So you can see our outpatient, our total visits, as our total visits increased, we went live with Epic in 2021. So that's why you see that green line going up since then. But to be able to see the financial turnaround, we're going to complete we just finished a year 19.5 million in the bank, which is a big deal for our facility from 7 days of cash on hand back in 2017, 2018. And that's just a testament to our team, but we've grown from 219 employees to now 660 employees. And to be able to take care of those families and those caregivers and to care for a region of 28 counties, it's really humbling.
And just a quick comment. I met Kevin in 2018 as he came in to take on the helm of Mahaska Health in 2018. And at the time, he said we were down to about 7 days cash on hand, and you can see the results. And 2020, 21, 22 obviously is hindered by the pandemic, but you can see post-pandemic the acceleration in growth.
And the biggest piece here is you have to have a healthy culture. It is crucial. And what people are talking about now is hey, come work at Mahaska Health because the culture is fantastic. The team works great together. And that's really summary of this slide. Recently, we hit an all-time high for employee satisfaction while national trends were going down in 2025. And that's just really neat to see that people can share anything and share ideas and be in a safe place and be able to move the needle for better patient care. And really, truly, culture is everything. And if employees feel safe to collaborate and be able to make changes for patients, and Other thing we do different too is we provide free coffee for our employees, snack carts, food trucks. So we do food truck Fridays. You get free swag, t-shirts, and we really do a lot of events for our employees, which is tons of fun.
Great. And just Kevin sent me the information around employee engagement, and I think you went from what 4.21 or 4.11 to 4.37 just in the last or 6 months or so. I mean,
Correct.
just absolutely startling results.
Yeah,
There is a
we
question there. Is there a question? Someone's raised their hand. I don't know how to make that work. It's first day with a Zoom.
look here.
Well, when we figure out how to work the technology, we'll get back. We'll answer the question. All right, it's Randy Nightingale. I, yeah.
I think that was an accident, Eric.
Oh, okay. Okay.
Yeah.
All right, Kevin. Thank you. Incredible results, as you can see, and just looking through some of the bullets, you can see some of that abundance slash infinite game mindset being played out. It's not about next month's results. It's this investment in culture. It's investment in a 10-year physician recruitment plan. Um, Kevin may not be here 10 years, but the investment is for 10 years out. I mean, it's really something. The next is Mary Ellen, and again, Mary Ellen has been the CEO of St. James Parish. And Mary Ellen, would you kind of take it and run?
Sure, sure. So I'm Mary Ellen Pratt, and I have the pleasure of serving as the CEO of St. James Parish Hospital. And I have been here now for 18 years. So it's been a long journey and a very rewarding journey. On your screen, you can see by the star where we are in Louisiana. We always refer to Louisiana as a boot, and we're kind of in the toe of the boot. But what is important about our location is that as many rurals are in very diverse geographic locations, we are in a pretty competitive market, very close to New Orleans and very close to Baton Rouge, two large metropolitan areas in Southeast Louisiana. So, as we are a rural community, a lot of agriculture, only 22,000 people, we are very much encroached upon by some significant metro hospitals. We were established in 1955. We are a public entity. So we are what they call hospital service districts. We became a COO in 2001, which was kind of at the beginning of small hospitals converting to critical access. We tend to be a one that jumps out first and tries new things. We've always been very innovative, and relocated the hospital, established a new one in 2008. Again, something that not a lot of hospitals had embarked upon. We were sort of one of those first to step out in rebuilding our hospital. Good. From a financial perspective, we've always done really, really well. We've got a lot of days cash on hand and have had double-digit pretty much profit margins. Some of that, though, I do want to be honest, we do get tax millage. We have community support, and so that has helped us maintain that margin throughout the years. So we've had that stability. And I will tell you, though, that millage is renewed every 10 years. So in my tenure, we've had to renew it twice. And so I think that holds us accountable to the community as to the value that we provide, and ensuring that they see that and are willing to renew that millage. Our millage was just renewed a couple months ago for the next calendar year, and we had like a 80% approval rating for agreeing to continue the millage, which shows the level of support we have from the community. But I don't want to de-emphasize the fact that we really work to gain that community support by ensuring that we're listening to the community for their needs and continuing to grow. Next slide. So this is kind of our the way we've structured our strategies throughout the time that I've been here, focusing on all these different pillars. And I think that having that structure has been important, but also very important is having balance in all of these things to make sure that you're moving all of these aligned all together. But I think the real difference with what has made St. James so successful is that we, number one, have a vision and always have a strategy. We create an annual strategic plan, a management plan that comes off of a strategic plan. So we always have vision for where we're going, and we march down that path. And I think that's very important when you talk about, the infinite games. It's about having that vision and knowing where you're going, and always being focused on that future, not feeling like it ends at the end of 1 year. It continues. But I think all of these great things that we've done have all been very focused on the people part of it and the collaboration part of it. We can't grow without partnerships. That requires relationships. That requires building relationships through people. And we can't improve our facility and have the service without our people being engaged and knowing, how they need to behave and service our community. So we really focus on building skill and building leadership in our organization, and the rest sort of happens because we've built that foundation of strong commitments to our community, our medical staff, and our team.
Fantastic, Marilyn. Again, it's that longer term vision turned into day-to-day operation plans. And last but not least, before we introduce Brock Slabach to discuss the Budget Reconciliation Act, we have Benjamin Anderson, CEO at Hutchinson Regional. Benjamin.
Thank you, Eric. Appreciate Mary Ellen and Kevin's comments, and these are two leaders I look up to, and we'll try to round out this part of our discussion. Overseeing a 190-bed regional medical center. It's a sole community hospital. We serve 30-ish zip codes all the way out to the Nebraska, Oklahoma, and Colorado borders. But most of our services are in our immediate, county and surrounding counties, that service area. But we consist of a medical center, a certified community behavioral health center that is integrated into our system, a durable medical equipment company, and a hospice and home care company. So we serve a lot of very rural and remote hospitals as well. And most of my career has been spent in those critical access places. So anyway, that's a little bit of a background on our service focus. We inherited a bit of, I joined the organization in January of 2024, and balance sheets hadn't been reconciled in 10 months. We'd had a negative 10% or $23 million loss in fiscal year 23. We were heading into a massive loss in fiscal year 24. We were the only health system in the country, or rather in the state, with an F leapfrog score. We had some serious quality issues, and so in all ways, many ways, always, it was a turnaround situation, and so there wasn't really a challenge in building a burning platform around change. I mean, we only go up from there. We were burning through or eating the seed corn, so to speak, and so we really had to lead a change. And what we did was, first of all, we just identified that just because it was doesn't mean it has to be that way. And we are capable of something different and better than this. And we had really good people. And so we led, first of all, with this idea that if you give good people good information, they'll make good decisions. And so we just I really appreciate what both Mary Ellen and Kevin were saying around leadership development and the capacity building within leaders. You give good people good information, they're going to make it better. And so what we did was we used improvement science to identify the right thing to do by asking the right questions of the people that those decisions or would most likely impact. So I will never have the context or insight that a frontline worker will. They know the right thing if they're engaged to do that. So we went through a strategic process where we asked them, what do we need to be doing to make this place better? They know. They already know. We took that, and invariably the payment systems are not in place to do the right thing. And so that's the challenge, is that you've got to hack the system, bootleg the funding, find the philanthropy, find if it's tax appropriations or wherever it is, you got to find the resources to do the right thing, and then meticulously track the outcomes for doing that right thing or series of right things. Because if you don't measure it, it doesn't matter. No commitment to measurements, no commitment at all. And then leverage the outcomes and tell the story, hopefully scaling it nationally even to affect state and federal policy, but you really do even solidify what you're doing. We've found that that's been successful within our approach. Go ahead and advance. So this is what our reality looked like, and then I'll round it out with a few of our interventions. So we got a lot of money during COVID. We got the monopoly money that came, but we built up our staffing capacity accordingly. The health system from 22 to 23 did not necessarily shed that expense of those agency nurses and other things, and so we ended up dropping way into the red. And having a pretty significant reduction in force in fiscal year 23. At the end of fiscal year 24 in June, we ended up with cutting that loss in half. And then this year we had a very narrow 0.6 profit margin and are showing that we are essentially entering a season of stability. Now, that's not a season of high profitability yet, but the analogy that I would give you is you can't control the weather, and Brock's going to talk about the weather, but you can't control the weather, but there's a lot you can do to weather it. And so we just focus on the soil that we're in, and flipping the soil, and removing toxins and improving the nutrition value in that soil, because you can tell a lot about the soil by looking at the condition of what's growing in it. And so we just focused really intently on building up our people, making benefit changes, engaging them in solutions and advisory council, and implementing their ideas, things like that. So anyway, Brock can share with you what we're up against, but I do think that these solutions are possible. They're possible if we work together to do it.
So as Benjamin noted, and he said it very quickly, he said, but he joined the organization 6 months into fiscal year 2024. And you can see the results as some of this abundance leadership was applied to Hutchinson Regional. So thanks, 3 hospital panelists, for kind of introducing your organizations, you, and how you think at the high level. All that, this first 28 minutes was about the introduction to the concept, infinite game, some hospital, 3 of the most abundant-minded, infinite-minded leaders that I've come across, their organizations. Now for the change event, now for the change in the weather. And obviously on July 4th, the Budget Reconciliation Act, there's a lot of different words for this act. I just keep it plain and simple. The Budget Reconciliation Act was signed into law on July 4th. And there's a lot of discussion around here, and obviously rural was a big piece of this. And Brock is actually now going to talk a little bit about it to set up the stage for a question answer, a panelist discussion around thinking of the impacts of what Brock's going to talk about. How do these 3 leaders anticipate going forward in their strategies and tactics? So with that, Brock, I've introduced him, but as you all know, Brock doesn't need any introductions. I think he's one of the most well-known names in all of rural America. And so we're going to have him talk a little bit about the Budget Reconciliation Act.
Eric, it's Hillary. Before
Hillary.
we move on to Brock's presentation, sorry to interrupt, I just wanted to point out that we had one question from the attendees. We had the question about how is the relationship with providers? How are you sure that they're listening? And on the board, what is the percentage of providers?
Well, why don't we do this? That is actually a question that I will ask them, each of the hospital panelists. That's one of the first questions. So let's hold off until we get to the panelist discussion. And if that's not answered, then we can bring it back up again.
Sounds great. Thanks,
Okay.
Eric.
So Brock Slabach.
Well, thank you, Eric, and it's indeed a pleasure to be on the call with such an esteemed group of people. I have the utmost respect for everybody that's on the call, and I would certainly encourage you to reach out to them if you have questions or comments. I think one of the things that NRHA has tried to do over the years is be a resource for best practices, and to not only instill best practices, but spread them. Because in an abundance mindset, we move from a fear-based kind of competitive approach to one where we look to creativity, collaboration, gratitude, and a proactive focus on sustainable solutions going forward. And so that's what I think we're trying to do here today. And I'm going to talk about the One Big Beautiful Bill Act, and I'll refer to it as OB3. I know many people have had different ways to denote that law, but I think that in any kind of effort that the government makes, there's going to be certainly stresses that it will place on us as providers. And so hopefully we'll be able to enunciate a little bit about what you should or could be doing in this environment to really actually take problems and turn them into opportunities. And so I think in backdrop here, one of the key points about the bill that was passed on July 4th that Eric mentioned, it now, according to the Congressional Budget Office, will increase the budget deficit by $4.1 trillion over 10 years. That is, by anyone's stretch of counting, a lot of money. And I think that we are certainly in a fiscally constrained environment right now. And so I don't know that new programs or services are necessarily going to be coming forward. So we have to look at our current set of resources and act appropriately. I will say that the congressional and media focus on rural healthcare was unprecedented leading up to the passage of this bill. I really, quite frankly, got a little bit nervous watching CBS Evening News and seeing reports about rural hospitals faring under this bill, because we got a lot of attention, which I think was actually really good. In fact, so much attention that the Senate would not have passed this bill had it not been for the Rural Health Transformation Program. And I think this is the bright spot, if you will, in the bill. And I'm looking forward to sharing with you some ideas about how this bill could be used going forward. In fact, it started at 25 billion. It went up to 50 billion. So Josh Hawley from Missouri, senator, has actually introduced legislation to take it to 100 billion. So I don't know that that's going to happen, but you can see the interest in rural health. I want to say at the very last here that this fund was meant for rural communities, period. I think that we are seeing alarming trends around the country regarding how states are looking to spend this money. And let's just say rural may not be the priority. And I think one of my efforts here today is to get as many people activated at the state level to make sure that that doesn't happen. Next slide, please. So this is just a real rundown of the biggest section of cuts in OB3 that was one of the pay-fors, even though they didn't get to 4.1 trillion. They did cut $1 trillion, more than $1 trillion, out of Medicaid. And so I'm not going to go over all of these. Our team in our government affairs office did a fantastic job of the OB3 update on July 30th. I would encourage you, once you get the slides, to take a look at that. Next slide, please. The cuts are disparate across the United States. So you can see the states here that have a dark blue coloring will have cuts of more than 13%, some as high as 20 and 25% as a result of the passage of this bill. But if you are in a non-expansion state, you'll fare much better. So the states of Mississippi, Alabama, South Carolina, and Florida are going to have way less than 7% cuts from their overall Medicaid spending in those states. And that's because most of the provisions in the Medicaid piece focus on what's known as the expansion population. And so if you didn't expand Medicaid, then you don't have a focus on that group of individuals. Next slide. So the Rural Health Transformation Program requirements, next slide, really, I think, sets the stage in the wake of those cuts and the alarming trend that that is going to set in terms of the future for the covered individuals in your communities. They created this Rural Health Transformation Program, as I mentioned already, $50 billion, and it would be eligible for all 50 states over 5 years. The first tier of funding goes equally to all states. So every state will get an equal share of $25 billion minus the 10% servicing fee, I'll call it, that states can use for the administrative overhead. The remaining 50%, or the second tier, we'll call it, is based on a criteria that the CMS administrator will follow. The law states the percentage of states' population located in rural census tracts of an MSA, rural health facilities in the state versus the number of rural health facilities nationwide. The situation of hospitals in the state, very subjective, so they could look at profit loss information for rural hospitals. There's a whole host of things that could be used in this bucket. And then, of course, that famous phrase, any other factors that the CMS administrator finds appropriate. The states must apply prior to December 31st. And what I mean by that is CMS, by law, has to have all applications approved by December 31. So we're assuming quite obviously the due date for these applications from the states will be well before December 31st. It's a one-time application for all 5 years. I can't stress this enough. This is a really complicated application that's going to have to be made that's going to be potentially well over $100 million for many states. And having to spend that much money in 5 years is a really tall order. I will make a comment that one of the requirements, or one of the caveats for the second tier of funding that proportional to rural populations, the law states that not less than 25% of states will receive this money, which means that Director Oz could theoretically award $25 billion to only 13 states. So this is another issue that I think we're going to be following very closely and wanting to make sure that there's an even distribution of the second tier of funding. Next slide, please. So I'm not going to go over all of this in exhaustive detail. You've probably seen it. This is actually copied directly from the law on the application requirements. So the state has to follow or address each of these items on the list in terms of its application to the federal government, to CMS for this funding. I will point out there's a couple of interesting line items like recruit and retain clinicians. I know workforce is one of the most significant issues that our rural healthcare rural healthcare facilities are addressing right now. I would say that you could develop loan programs, for example, or scholarships similar to the National Health Service Corps that are state-based that could incentivize individuals getting medical degrees and nursing degrees and rehab degrees, et cetera, to be able to locate in a rural community. I will also say that it outlines strategies to manage long-term financial solvency and operating models of rural hospitals. I think that this really makes a good case for states to be investing in technical assistance for rural hospitals. So there could be a TA component that could be included in a state application. I think also this would indicate to me that states could look at retiring debt or helping assist with debt retirement for facilities that are struggling financially, and creating a program for that to be implemented. I'm just talking out loud in terms of the ways that these monies could be spent by states to help rural hospitals. Next slide. So the state the law states that there are uses of funding, and that this is the list that the law requires that the states use to create their application for funds. The states must plan to carry out at least 3 of these activities. So it's kind of like going to Panera. You pick 3 here, and you can do more for certain, and certainly with well over $100 million a year for many states. It's going to take a lot of activities to spend that much money. I can't stress that enough right now. There's going to have to be a lot of creative work being done to make sure that those applications are appropriate. I've heard a number of facilities asking about, for example, the technical assistance software hardware for significant tech advances. I would say that there's been discussions about EHR upgrades and using the money to afford technology that hospitals would not otherwise be able to afford in a rural environment. Next slide. Now, here's where it gets really interesting. You can look at the eligibility of facilities. The law states what they are. We're really pleased that the hospitals are defined using the FORHP definition. So it includes hospitals that are in rural census tracts of metropolitan statistical areas. So we were pleased to see that the Senate, in their language, used that. Unfortunately, the night before the bill passed, there was a provision slipped in that allowed for hospitals that are treated as being located in a rural area to be added. So this will include now 425 or more rural referral centers that are in urban centers that would be eligible at this point to receive the funds according to the law. In fact, I have an article linked here at the bottom that was just published on August 4th that talks about the sharp rise in urban hospitals with rural status. And so I think this is something that we're trying to get the word out on so that states aren't bombarded with applications for funding from hospitals located in Chicago, New York, and other cities that have these facilities. Next slide. So what are some of the strategic and operational dimensions for hospitals and clinics, especially looking at the abundance mindset here? As abundance thinkers, we really should set our feelings and opinions aside on OB3. It's now the law, it's what we have to deal with, and the reality is what it is. And now we have to set our sights on our survival, or is it going to be one of scarcity and closure? I think that it requires us to reread the OB3 law as a strategist. What would we be doing in response to this to preserve access to our communities in terms of healthcare? And the preparation for this begins now. I can't encourage that enough in terms of analysis. So what is that? What could that analysis include? Next slide. I think strategic implications, and a lot of times the work that we do is stating the obvious. I think it's very powerful to actually state what the reality is. So we will see decreased Medicaid covered patients, which will then increase bad debt and charity. And so this is going to come from work requirements in the expansion population. They may need recertification assistance. So you may look at adding people in your communities, community health workers, different kinds of personnel to assist in making sure that on those 6-month recertification timelines that you get them updated with insurance on those timelines. I will point out that the enhanced premium tax credits will expire December 31st. This is a way that many rural patients of yours have been able to afford health insurance through the marketplace exchanges. We're estimating, according to the experts, 4 million people uninsured as a result of the expiring tax credits. I saw this morning that Senator Shaheen from New Hampshire is going to be spending some time this fall trying to work her hardest to get this enhanced premium tax credit renewed. But I'm afraid in this fiscal environment, it's an uphill battle. Care for these individuals will shift to emergency departments and FQHCs. Obviously, in our emergency departments with HIPAA requirements, They will be seeking care after hours and perhaps on weekends and even during the days because they know that they can't be turned away. And so that's one of the things that we could be looking at in terms of a future. The provider tax limits, the state-directed payment changes. I was just in Kentucky yesterday, and they were talking about how state-directed payments are going to be a significant hit for rural hospitals in that state as a result of this bill. And then, of course, remember the Rural Health Transformation Program is an important program, but I would encourage everyone to look at how you can monitor or actually evaluate the gaps in your funding going forward and making sure that you communicate those gaps to your state leaders that's going to be completing the application to the federal government. Federal deficits are expected to be now over 4 trillion rather than 3 trillion. And it could invoke the Pay-as-you-go Act, which was passed in 2010. Now, the Congressional Budget Office just Monday of this week issued a warning to Congress that given current factors, an implementation of a 4% sequester for Medicare funds will be required at the end of fiscal year 26, which will be September of next year. So we're monitoring this very carefully, but I think that providers need to be looking ahead very concretely with the possibility that this 4% sequester on all Medicare funds could come into play. And what would that do to the situation in your funding for your facility? I'm not trying to scare anybody, but I think that, again, the reality is that there are downstream effects from these kind of programs, and we need to be anticipating those. And I would include those in your gap analysis because, again, that $50 billion was intended to help mitigate some of the gaps that we're talking about here in this conversation. So model your hospital's exposure to all of these cuts that are being potentially considered. Share the impact with your state leadership. Let them know your gaps as they fill out this application and what it would take for you to be able to use some of the funding for your facility. And then lastly, review and update your charity care policies because I think that the stress of your facilities are going to be increasing over the next 10 years. Next slide. I would look at your staffing and how you're going to facilitate increased denials, redetermination decisions. What is it going to do in terms of your staffing resources to be able to keep up with all of that? Again, put that in your gap analysis and share that with your state leaders because this is part of the cost of dealing with the impact of this bill. Monitor the state's application. I cannot stress this enough. Be involved in the writing of that plan as much as you can, and that ensure your rural health system is operating at maximum efficiency from a volume, revenue generating, and expense perspective. And I think that taking advantage of resources like strategic financial operational assessments and other strategic reviews of your facility and its future could be very instrumental. Next slide. And that concludes my offering here this morning in terms of what it is that we need to be doing over the next 5 to 10 years and making sure we use every opportunity to initiate and use those Rural Health Transformation Program monies. I will say that the congressional intent for this money, for these $50 billion, was for rural hospitals. In fact, Senator Barrasso from the state of Wyoming, in his press release on this bill being passed, called it the Rural Hospital Transformation Program. So I think that this tells you where people's focus was on that. And I think that that's where the placement. And the reason why hospitals are important, I want to stress this too, and I'm going to go over 20 minutes now with this, but hospitals now employ most, if not all, of the primary care workforce in their rural communities. And if you lose the hospital, you lose the employment base for an entire group of individuals that are caring for patients in their clinics and in other areas of service. So I just want to point that out, and that we need to stand firm on the use of this money for rural hospitals. And with that, Eric, I will turn it back over to you, and I'm happy to stay on to answer any questions.
You're probably going to get a bulk of the questions, so I'm glad you are going to be staying on. So Brock has just laid out essentially the change in the weather, using that analogy. We're going to be going from summer to fall over the next 2 years to winter in the next 2 years after that, as essentially more people roll off of Medicaid. The direct payment programs are going to be impacted. And then there's this uncertainty around the rural bonus. So the weather is changing, like the seasons are right now. And what I'm really interested to hear is how the three CEOs, the panelists of CEOs, again, some of the most abundant-minded thinkers that I've come across in my 28 years, how they are thinking about essentially, Brock just introduced some things that hospitals should do should be thinking about. How do these three individuals think about the impact of the change in the weather through the Budget Reconciliation Act, OB3, on their operations? And so the questions, it's really the main question here is given the anticipated impacts of OB3, how will your abundance game or abundance infinite game mindset influence your hospital strategies, finances, operations, over the next 24 months, and specifically around revenue cycles, staff recruitment, medical staff, economic uncertainty, volume growth, expense management, culture, community engagement. And I'd like to spend, some time listening to these folks talk a little bit about that. We heard, I think the question that was already asked that Hillary jumped in and asked was around medical staff recruitment. Obviously, with some of the cuts that we're seeing on the horizon, does it mean we back off on medical staff recruitment, start to kind of circle the wagons, or what does it mean to our medical staff recruitment? I'm opening it up to the three. I could point at you if you wanted.
Mary Ellen?
Sure, I'll start. I'm really not changing my recruitment strategy. I'm continuing to forge forward on some pretty big recruits, honestly, because I believe that we're not going to be able to cut ourselves out of this challenge. We're going to have to also grow. You have to do a little bit of both, but you've got to grow. And so we're really looking at doubling down on some of the strategies that we have, recruiting an orthopedic surgeon, working with our physicians who we know are leading into retirement years. I have really, really strong relationships with my physicians. It started with us, as I think Kevin and Ben both alluded to. We have them at the table working with us on strategy all the time. It's not a top-down strategy decision. It is, let's sit together and figure out how we work to make this happen better. And so I'm listening to my doctors as they are making plans to retire, and I'm building the succession plan with them to take on those practices and to move it forward. So I have not stopped my recruitment. I don't think that that's a smart move. I'm looking at GI, I'm looking at urology, because of retirements that are probably within the next 3 years. We're really actively working orthopedics because I believe those specialists is what's going to continue to fuel the hospital for that sustainability. So I really haven't stepped away from that. I do believe, though, that we may have to realign some of our relationships, and one has to do with how my model works in the emergency room, with how the subsidy is working, and the assumptions that were made in that contract when established are maybe different in the future world. So how do we work more collaboratively on bringing that into today's kind of dilemma, and how we plan that together? But I definitely have most of my physician contracts where they're performance-based. So we are aligned on the goals that we're trying to reach. And so the funding is aligned to the performance of those goals. And I think when you work with physicians in that way, you create the alignment that you need to get the results that you want. And they're participating in that, and it becomes more of them working on it because they want to work on it versus being forced to work on it.
Awesome. Awesome. And when you're talking about aligning contracts with organizational goals, I'm assuming this goes beyond just work RVUs. You're looking at building in quality and patient satisfaction and other. Okay, great.
Absolutely. Absolutely.
Kevin, what are your thoughts here on medical staff recruitment?
We're doing the same thing as Mary Ellen. So yeah, the 10-year recruitment plan, we understand which physicians, mid-levels are planning to retire or do something different. We have those open conversations, and then we as a team, we meet weekly to go through recruits, students, residents. We host surgical residents, so we're always visiting and talking with those individuals. We're bringing on 8 new providers here in September. So that includes PM&R, a second urologist. There's cancer care is a big piece that we're going to be expanding in. And so, yes, I agree with Mary Ellen. We got to keep growing and keep building the team, because, the weather's going to do what it's going to do, right? And so as long as you take care of your teammates, that'll be fantastic. But I do want to answer Javier's question. We're a county hospital, so we cannot have true physician board serving on the board, but we do have our 3 physician executives attend the board meetings, and then they also give updates, which is really helpful for the board of trustees that we have to hear directly from the clinicians. And then our executive physicians lead our physician medical director meetings where we meet monthly. And that the efficiencies in those meetings has produced so many great upgrades with our Epic electronic medical record. It's brought together peer-to-peer relationships, and just provided a lot of efficiencies throughout the entire facility, because when they're at the table making decisions, we as an administrative team put together those action items. So I want to make sure we get that question answered.
Awesome. Benjamin,
Well,
medical
first,
staff.
I love doctors. It's one of my things about this job is working with doctors. And so what we did was we used some. I agree with what Kevin and Mary Ellen did. They're not slowing down on medical staff recruitment. We're using data, and I'm sure they are too. We're using data to make those decisions, and so we have a decision support team. Sometimes we pull in Stroudwater or other resources to do it, but we essentially do a comprehensive assessment of what the financial impact will be. What's the downstream revenue? What's gonna be the loss for employing them? Because there's often a loss for their professional fees versus their salaries. But you make it up on downstream revenue. We do those analyses, and we make sure that that the positions we're adding are responsible. But before that, I think we did an environmental assessment, and we used the community AppGuard framework out of the University of North Dakota School of Medicine to assess 50 criteria, 5 categories. What's it like to live and work here? We asked the doctors and the nurses what it's like to do that, and we got the data, and we got the strengths, the challenges, we got their highest priorities. We began planning interventions around what they said to essentially improve the content of the soil where we're planting them when they come out of residency. And as we've made those changes, we set out a bold vision to recruit about 50 physicians over 5 years into our community, because over half, over 50% of our med staff 2 years ago were living outside the county, and that's devastating to a local economy. And so we set out just to start with the emergency department, flip the emergency department from a bunch of 1099 folks coming in from 3 hours away to local folks that are living and working here. And just doing that in our emergency department is it's like the chamber recruiting in a business with 5 million in payroll. Just the emergency department. That's not even the hospitalists. That's not all the other areas. We found philanthropy that would give $50,000 housing bonuses to folks if they would buy a home in the community and it's connected to 3 years of service. They work it off, so it's taxed over 3 years. And so some donors work through our foundation to do that. And then we're recruiting in bulk. So the way KU recruits basketball players, where the recruits recruit each other, we go to the recruits. We're flying in 20 physician residents twice a year in for a recruitment weekend, where they get to experience what it'd be like to live and work here, and kids and why sports and schools and what did this be like? So we're essentially ushering in the next class of medicine here, and in various specialties, because many of them went to med school together and just chose different specialties for residency. Nowhere else is offering them a chance to practice with their friends and near their friends, and that could be done at a small scale or a large scale. We did something similar when I was out in Western Kansas in a town of 2,200 people, recruiting 20 doctors to the region. But again, to Eric's point earlier, with an abundance mindset, it's not a finite pie. You can recruit more access within the region. Everyone can win if you set it up that way, unless you're against each other and you don't trust each other, right? And so we've just found allies, even within our own community, that we don't really care as much even who employs these folks. So long as they work in our workshop and they're shopping at Dillon's grocery stores and they're in our schools and raising the paddle at the local fundraisers. And I mean, we want them there. And so that momentum is built. And at this point, we're now having to shut down some of these searches and say, okay, we're not recruiting to these specialties. It's no longer come one, come all. We're now being very targeted, as it sounds like Mary Ellen and Kevin were. We need this special. We need an orthopedic surgeon, right? We need 2 more pulmonary critical care doctors, or we need more primary care, and focusing on those things. But ultimately, the physicians are the compass of a health system. And you start cutting on them, you cut your nose off to spite your face.
What's interesting is that, each of the three of you, the responses that you gave to this question back in June have not changed
No.
by the reality of the budget reconciliation OB3. It's
No.
still pedal to the metal, which is incredible. I want to move, and then I want to touch on a couple more of these, and we only got about 10 more minutes. Expense management, right? Expense management. You would see with a lot of people coming off the insured, less dollars coming into our system. We could get scarcity real quickly and start cutting and looking to cut FTEs and cut benefits and cut things to make up for the budget deficit. Benjamin, how are you thinking about expense management?
We have a committee that looks, first of all, a position control committee, and right now, especially till we know how this beautiful bill is going to affect us, every position that is vacated goes through to refill it, goes through a position control committee. And we're analyzing, could this work be done by the remaining or existing team members without causing burnout or harm? Could it be done that way? Is there a way to rethink who does what? Is this absolutely necessary right now? So I wouldn't call it a hiring freeze, but maybe like a hiring frost. Like we really, it's just accountability, where people are going in front of this position control committee that's a diverse group from around the organization that really has the best interest of the organization in mind. And so, I mean, our biggest expense is labor. And so we do that. And then we're evaluating CapEx and what's absolutely necessary. And then we're actively right now engaging philanthropy to fill some of those CapEx projects within the community. And really, it's communicating the message that Brock just shared with us. That's gnarly. And that's outside of our organization. We can't control that necessarily. Fortunately, we have NRHA and others doing that, but we communicate that. We're inspiring folks with resources to say, we don't want our hospital to fall down. We're willing to pitch in. And so we'll help you redo your cath lab. We'll help you with recruitment of a new primary care doctor. We'll help you with hosting certain events or engaging in ways that they can. So I think we're just looking at those expenses tightly, but not so much so that we're harming the organization in the process.
Thanks. Kevin, Mary Ellen, how are you guys thinking about expense management? Are we going to go scarcity on us?
No, I think I'm doing somewhat the same thing Ben's doing with regard to attrition and looking at those positions and making sure that there's not another way that we could serve and accomplish that task in a different way. So we are being very mindful. But I think one of the things that we're doing on the expense side is that we've got this independent group of hospitals that have come together in Louisiana, and we're really trying to leverage that scale on some things. And one in particular is on health plan and how we are trying to drive business into our local hospital and trying to reduce the cost of a funded health plan by getting other hospitals to adopt the same plan and lowering the cost for all of us. So we're working in that space right now to see how we can. There's a couple of us that are looking to join together on a model health plan that will reduce costs for all of us by being a larger collective. So there's things like that we've kind of stepped up a little bit, given the fact that there's a little more stress in the future. And so we might need to, move these things along a little bit faster.
Yeah, a well-designed, self-insured health plan where the benefits encourage healthy behavior, discourage unhealthy behavior, elective unhealthy behavior, where you incentivize the employees to use your own organizations rather than going out of network. It's one of the greatest opportunities that we have. But it's
Yeah,
got to, the plan design has to be very well done. And then using your abilities to look at claims and start to understand where out-migration is happening. So good stuff. Kevin, what do you got?
A lot of the same things they mentioned, but something we did during COVID is, when everybody was furloughing and terminating employees, we actually gave all 200 of our nurses a $5 an hour increase. Because why would we pay $200 an hour for contracted labor when we can reward our greatest asset, which is our people? And so always be thinking about, rewarding your own team so that they really step in and able to carry the load. Another thing we did too, construction costs as you grow, right, are very expensive. And so we actually hired an in-house construction crew back in 2019. And all they do, these four individuals, is go from job to job internally. And guess what? They get inside, no weather elements. They're always inside doing work. And they've saved us millions across our health facility just by doing in-house construction work.
Thank you. That's good stuff. I'm
Eric.
interested. Yeah, did somebody?
Yep, Eric, it's Hillary. I've just jumped in to let you know that we do have some really great questions in the Q&A.
Yep.
Are
Yeah,
you
we
ready
got
for
about
those?
7 more minutes, and then we're going to spend 15 minutes getting into some questions. So
All right, sounds good.
Yeah. Revenue cycle. I mean, this gets a little tactical, I think, but obviously with more folks going to be rolling off the insured dockets, and kind of. Are we rethinking about revenue cycle, or we're waiting and holding at this point to see what comes down the pike? Mary Ellen, are you doing anything on revenue cycle?
Oh, we're doing a lot on revenue cycle because what I feel like is when we've got to collect every nickel we can. We just can't let it go out the door. So we've got to figure out how to stop these denials and work this stuff more efficiently. We're implementing some software. One is to help us understand denials and things. But again, I go back to collaboration. This is some software that other link hospitals are going to be implementing at the same time so that we will have data across health systems on behavior of these managed care companies, not just our own data, so that we can then get a little more of a collective. One of the challenges is in a small hospital, you don't have that much volume. And so something might happen one time and you're like, why that denial happened? We can't figure it out. But in a larger system, those things hit a lot faster. They find out about it a lot faster, and then we can get proactive. So even before the denial hits us, we know from our other hospital that, hey, this is happening. You need to put put these things into place to manage that denial. So we're working across hospitals on building that. Louisiana Hospital Association has got this payer card scorecard now through Hive, where we first started seeing our data, and we can see automatically that we're having a whole lot more denials than other people. Why? And start learning how we compare to our colleagues at different size hospitals and stuff.
Right.
So I think that that's going to be really important to be able to leverage that information to be able to collect every nickel that we can.
Great. So supercharging primarily that front end and frankly on the back end regarding the denial. Benjamin, Kevin, as a result of OB3, have we sat down with our revenue cycle team and said, "Hey, new sheriff's in town here. The weather's changing, the season's changing."
We have absolutely been working on revenue cycle, and it remains a forefront concern for us. We saw some pretty big progress over the first quarter or 6 months of this calendar year, and have seen it level out recently. And candidly, I'm not exactly sure why. We are calling in an operational audit around our revenue cycle as of this last week, because to Mary Ellen's point, we need to be able to capture every nickel that we're working for. And some of that, we also coupled with that, and we're a small PPS hospital. We need to make sure that our length of stay is appropriate. We need to make sure that our case mix index is accurate. And if we're not tracking that data, we can't possibly know. And then are we billing? Are we coding? Are we documenting all of those pieces? Because I think there's a caution I would share with the group that we learned is providers that are undertrained in documentation and coding will undercode what they're doing because they don't want to end up in an orange suit.
Yeah.
Understandably, training will allow them to not excessively, but accurately document what they're doing to ensure we get paid for the work that we're doing within the system and within the boundaries of the law and ethics. So I think we have more room to grow there in ensuring that every clinician is documenting properly.
Great. All right. Beautiful.
Then there's
Kevin.
with the bills.
Agreed. Ben hit something really good. We actually sent one of our physician executives to Epic training. He's a master trainer. He meets with all new physicians before they start at Mahaska Health and optimize coding and billing, make sure they understand what the drop downs mean. That's been a big piece for us. We did move to KeyBridge, which we've seen an uptick of patients to the tune of 35% paying bills with the online app. That's been a big deal for our facility. But the other piece we did too is revenue cycle starts at registration. Having registration sit with a biller and our billers sit with registrars, really, that's where everything starts. And the eyes that have been opened there and the efficiencies created has been huge. We never used to collect copays. We're now collecting $250,000 a month in copays. And also, we're making sure we look at our super bills, making sure we're working our denials. And our entire revenue cycle team, they get together weekly to review their KPIs. And it's made a huge, significant difference.
So what I'm hearing is really for these bullets, I'm hearing the OB3 is interesting. It will impact us, but we're going to double down on everything that we've been doing. I'm seeing some nods. Ben, I think he fell asleep, but the other guys are nodding.
That's right.
Yeah.
That's right. I'm taking notes.
I don't want to we are doing these things for our hospital, but one of the things that Brock brought out was, keeping tabs on what the state is doing and how they're working on a plan for that grant. I'm also very engaged in monitoring that and working with the folks that are on that task force on what kinds of solutions would be the most impactful. So, this is what I'm doing in my hospital, but when it comes to OB3, I'm also doing things to raise the awareness about what rural really needs at the levels for where those applications are going to be crafted.
So that may be the last bullet there. If you were to give a top recommendation, essentially double down on your own hospital business, but then get involved around some of this, the future direction of this, the rural hospital transition funds. Um, um, uh, 15 seconds. One recommendation, Benjamin? This last bullet around ensuring your long-term viability. One recommendation, 15 seconds.
Meet regularly with your team and ask them how to make it better.
Awesome.
We do it monthly over our birthday breakfast, but you can find a platform to do it. Ask them, they'll tell you.
Kevin?
Same here. Engage your physicians and make sure that you implement a healthy culture. Because if people start serving each other, guess what? Then they start serving the patient, and the patients will figure out what's going on.
Awesome. You guys are superstars. So we've got a bunch of questions popping up. Hillary keeps hounding at me to ask to butt in here and ask questions, which I asked her to do, and then I've ignored her. But we've got about 15 minutes just to touch base on some of the questions. Hillary, can you group any of them around topical areas? And Brock better get ready here because I think they're all going to be directed at Brock.
Brock's been answering the questions that are targeted to him, so that's been really helpful. But one question did come in about revenue cycle, so maybe we could start there, and then I think it's going to be a little bit broader on the OB3 impacts. So I know that we've just kind of broadly talked about revenue cycle, but somebody asked, what are your top 3 to 5 keys for efficient revenue cycle to maximize reimbursement?
Whew.
Top 3 to 5 keys. I mean, first of all, you have to work your denials, right? That's a must-have. If you leave that on the table, you're leaving millions. Physician engagement on, how are they billing in the bell curve? How are they coding, right? Making sure your certified coders are regularly meeting with your physicians. And then just making sure your leadership is aligned and giving you the straight picture on your KPIs in your facility. That's crucial. You got to have the data. Otherwise, you're losing cash.
That's perfect. Mary Ellen, Benjamin?
I would agree with Kevin. I think we have a very robust dashboard that we monitor. So you've got to know where your numbers are to know where you need to focus. And we have an interdisciplinary team that works it. So I think those things are important. But I also think that it's important to see how how the payers perform and compare that to peers. And we're going to be using that in our managed care contracting. So I'm taking it back to the managed care companies as to what we're seeing and how we're different.
Mary Ellen, friend of the firm, Jason Amrish, did ask maybe in the future if he could see one of your dashboard examples.
Sure.
Yeah. I've always said that the 3 keys to it used to be just 2 keys to revenue cycle success is a measurement culture, a KPI that drives, with targets established for the KPIs that drives weekly revenue cycle team meetings to address systemic issues. Number 1. Number 2, it's always been move all the effort to the front end. Scheduled services, point of service collections, as much as we can to move. And then in the last 3 or 4 years, the third kind of key to success is denial management. I was talking to a hospital yesterday who in 2024, their denied claims were 4.9 million. Through 7 months of this year, they're already at 9.5 million. And speaking with this CFO, she said our denial management program is a disaster. We've got to straighten this out before somebody's impacts. So, Benjamin, I cut in over you.
I think to compliment what others are saying, I'd say know what our team knows and know what they don't. And it's okay that they don't know everything right now about revenue cycle, and then analyze what of it is wise that we do internally and what of it is wise that we do externally. Do you need to engage an external partner because billing and coding is becoming so specialized, and because it is becoming such a remote workforce economy around revenue cycle? Does it make sense to outsource part of it? We have insourced everything else in this health system over the last 2 years. The only thing that we're still playing around with is, do we have other folks help us with coding? Do we have other folks help us with billing? I don't know a high performing health system that cuts on coders or cuts on billers. you staff those areas and make sure they can get things coded properly and bills out the door. So make sure they're well resourced, but just be honest about what we know and don't know. Just because someone's local doesn't mean that they have what they need or can get what they need to do it. We need to be realistic.
Yeah. Thanks, guys. Next question.
Wonderful. This one's a little bit longer, but we're going to head into more of the OB3 specific questions. They're going to be a bit broader. So someone ahead of today asked, how can critical access hospitals strategically leverage the Rural Transformation Program to accelerate readiness for value-based care models, ensuring they maintain the benefits of cost-based reimbursement while building the care coordination, data infrastructure, and risk management capabilities needed to compete in a fully value-driven rural healthcare environment over the next decade?
Wow.
Well, that was a mouthful.
I'll tell
It
you,
was. I think I
need
got
to,
it.
I need to write that down. That was an impressive question.
I will put it in the chat as well for everybody.
Brock, do you want to take a stab at that one?
Yeah, I think that what I hear in the question is resource generation for building the foundation of what facilities or a group of facilities can come together to accomplish. And I'm thinking of now high value networks, looking at how communities can band together to become more sophisticated in all the things that we've just been talking about, and using the resources. So one of the slides that I wasn't able to fit into this presentation today is think through what rural health transformation programming could include and that would incentivize you to do something different tomorrow than you would if you did not have that funding. In other words, it gives you the platform to be able to build infrastructure to get outcomes that you wouldn't have been able to do on your own, because a lot of these are very capital intensive. So building a network, for example, can be very capital intensive. The folks up in North Dakota spent a state appropriation of $4 million roughly to get their network going from 0 to 60. I used the Pennsylvania Rural Health Model. It was a $25 billion CMMI grant to the state of Pennsylvania to develop a global budget. You had the Accountable Care Organization Investment Model back in 2017 that created Medicare shared savings programs. But all of those had an infrastructure piece that had an intensive amount of work that had to be done behind the scenes to be able to make that happen. And so rural health transformation programs can come in and use that money to fund those types of initiatives to be able to assist you in the efforts that would yield the value-based care objectives that the questioner asked.
I'd also like to give a operational answer to that question is make sure your clinical individuals, your medical staff are working at their license level, right? So we hired care coordinators that follow up with the patients. So our physicians sometimes can just get the message, but also we specifically hired 5 utilization clerks, non-clinical, that all they do is prior authorizations. And, allow your nurses to nurse and your physicians to see patients, and those efficiencies will really pay off in those type of value-based models.
I like these answers. I'll go back to the self-insured plan that was mentioned earlier. Find a way, no matter the size of your community, to band together to get 10 to 15,000 lives, even if it's in multiple towns. Find a way to get there. Pick the right partners that will price things appropriately, and figure out how to self-insure and get the right third-party administrator to process those claims. You then have access. You have control of the data. You're driving that care into your local community. You're keeping it local. Those incentives will keep people local, and it will make you less vulnerable to the whims of what's going on in Washington and your local state capital. So I think the more that can happen, the better.
I think we might have time for 2 more questions, and I'm going to end with a more like high level one. So I'll ask this first one. This person came from Texas. They did say Texas did not expand Medicaid, but still worked with the federal health funds for UC, DSH, and other programs. Are we to assume these programs will be affected by the potential Medicaid cuts? Also, post-COVID, we try to run a pretty lean ship. Are there any suggestions on the services we can grow in our hospital with a community that is sadly both aging and declining? So I kind of asked two questions in one, but that is one of our second to last question.
Ashley, can you repeat that acronym? I think you kind of cut out during the
Yeah,
middle.
they said Texas didn't expand Medicaid, but still worked with federal funds for UC and DSH.
Oh, uncompensated care. Yeah. The answer is complicated, but if it's part of a state-directed payment program in Texas, it will be limited to 110% of Medicare. So if the program is paying now currently more than 110% in a state-directed program that addresses uncompensated care, then they'll have to roll that back to that 110% threshold.
Wonderful. And maybe for the larger group, just thinking about when you think about your own communities, are there specific places where you're thinking about growing service lines for potentially aging and a declining healthcare community?
To answer that, Ashley, anytime you can get pain management, medical oncology, urology or ENT services, for that population would be fantastic. They're going to utilize those services. It just takes the right people, the right team to come together and to open your doors. Those practices will fill.
Awesome. Okay, so I'm going to end on all of you maybe kind of answering what your dream projects would be if you could kind of dictate how the rural transformation funding was being used.
Wow, that's good. I've
From some
actually
friends.
spent a little time thinking about this, and I truly think that the applications that would be meaningful is to do something that, again, I'm not trying to be repetitive, do something that you wouldn't have done otherwise. And I think that you could do it at a community level. You could come together to an application to the state to create something innovative. It could be regional or it could be statewide. The problem with each of those levels is the increasing complexity grows in terms of the stakeholders that have to come together to put the application forward. Because remember, I'm guessing that the applications from states will need to be due in November sometime. So you don't have a long time at this. So what I suggest to folks is maybe not have all of the answers, but create a think tank, maybe a working group that would implement similar to the global budget program in Pennsylvania. They got a $25 million grant from CMMI, and the grant was to initiate the global budget. They didn't implement the global budget on day one. It took 2 years to set up that global budget mechanism, which then went into effect 2 years, 3 years later. So I would think in an innovative way what you could do to create change around the incentive. So I'm thinking really way out of the box here now. And how can you create a multi-payer environment around care for patients in the community, and in creating that network that can help to make that happen? I'm going down in time now, but working towards that as a goal at the end of 5 years. That's just a thought.
Yeah, I just, one of the things that I've just been passionate about the last 3 or 4 years is no longer thinking about our community as patients, but thinking about them more as people, as community, which means how are we going to create active outreach to our community, not only when they're sick, but also around health, annual physicals and annual wellness visits and chronic care management, all of these opportunities. And is there an opportunity to use these funds, these rural transportation or transition funds, to help support the development? Is kind of what Kevin was talking about, caregivers, to support our primary care with more proactive outreach. It's where administration wants to go right now. You know, Robert Kennedy Jr. is the whole CMMI initiative around engaging people in their health. What happens if we got some funding through the rural transition funds to fund some of these costs for us, that we could truly make inroads into our community as people rather than patients? Anyway, we are at time with these four panelists. There's an abundance of information, of knowledge, of words that that we all share. We appreciate, you know, everything that you all are doing out there. Appreciate you listening in this morning, this afternoon. And if you have any questions, again, as was said earlier, I think Brock mentioned, reach out to these folks. These are as collaborative folks as you're going to find. And so reach out to them and ask questions. Reach out to me. Reach out. Let's figure out how to solve this thing going forward. So with that, I want to thank the four panelists for sharing some of their thoughts, and wishing everybody a great Friday and a great weekend coming up. Enjoy the last of our summer here. Appreciate you all. Thank you.
Bye,
I
everyone.
wish it was the last of the summer.
It's 53 degrees this morning here in Maine.
Come up to Maine, Mary Ellen.
It was
Thanks,
nice.
everyone. Take care.
Thank you,
All right.
everybody.
Great show.